Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is December 7, 2025. This video is on a review article published last week on 26 November 2025 in the American Heart Association Journal of the American Heart Association. The video is on immune checkpoint inhibitor therapy and acute coronary syndrome, a review of mechanisms and management. What are immune checkpoint inhibitors or ICIs? They're monoclonal antibodies targeting CTL4, PD1, PDL1 or LAG3. How many ICIs are FDA approved? 13 across 20 different cancer types. Why are ICIs linked to cardiovascular toxicity? They amplify T cell activation and inflammation. How common are adverse events related to these inhibitors? 60 to 80% higher with combination therapy. How common are cardiovascular adverse events? Rare but serious. Myocarditis 0.3 to 0.5%, myocardial infarction about 0.7%. What is the risk of MI in ICI treated patients? Up to 7-fold higher than controls. Which patients are at the highest risk? Older age, men, hypertensives, higher body mass index, and those with underlying baseline coronary artery disease. Are cancer patients prothrombotic? Yes, 7-fold higher venous thromboembolism and also an increased arterial thrombotic events. Do ICIs accelerate plaque progression? Yes, especially non-calcified plaque. Do all ICIs carry similar risk of acute coronary syndromes? Combination therapy increases severity. How does PD1 blockade promote atherosclerosis? It enhances T cell cytokine activity. What happens to macrophages? More apoptosis, resulting in larger necrotic cores. What is the role of CTLA4? Loss destabilizes plaque. Do plaques show immune exhaustion markers? Yes. PD1 plus T cells are seen in the unstable lesions. Does dual blockade worsen plaque? Preclinical data, 2 to 4 times there is infiltration by inflammatory cells with dual blockade. How does acute coronary syndrome present? Chest pain, shortness of breath, low blood pressure, hypotension, often atypical. Why is diagnosis harder? Because of variability in baseline EKG and troponin. Does myocarditis mimic acute coronary syndrome? Frequently, and geography is the key. Can ICI trigger vasospasm? Yes. Cancer therapies predispose to vasospasm. Best imaging, coronary angiography, and CMR for myocarditis. First management step, stop the ICI and treat the acute coronary syndrome conventionally. Are steroids used? Only if vasculitis is suspected. Is PCI underused? Yes, due to perceived bleeding risk. What is the duration of DAPT in these patients? 1 to 3 months in high bleeding risk patients. What about rechallenge with immune checkpoint inhibitors? Rare, requires multidisciplinary review. Do statins help? Yes, slows plaque progression. Do statins improve tumor response? Evidence suggests synergy. Role of PCSK9 inhibitors? Synergistic with PD1 blockade. What about use of coronary artery calcium on routine CT? Yes, it predicts future cardiovascular disease events. Is a risk score available? Not yet. Most urgent research, mechanistic studies on thrombosis and plaques. What's the role of coronary CT angiography? Promising for early detection. Should all ICI patients start statins? No, because the risk of myositis and hepatitis. Do adverse events predict ACS? Unknown. Future guidelines likely to include ICI-specific acute coronary syndrome pathways. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.